So that is that. We should not forget that ketogenic diet for someone with pyruvate kinase, pyruvate dehydrogenase enzyme problem. So, Dr. David, before we move, can you quickly remind us the coenzymes that are involved in pyruvate dehydrogenase enzyme complex?
Okay, the vitamin B1, B2,
B2,
B3,
B3.
uh, B5, and lipoic acid.
Exactly. So, what is the effect of arsenic, on that pathway?
It's it's in this lipoic acid.
Inhibit lipoic acid. So that process cannot proceed. So how do they present arsenic toxicity?
With that vampire, wherever. I don't know.
The what?
The skin changes, kind of the
Skin
skin. I
changes.
can't remember. Uh,
Yeah. So once you see your skin hyperpigmentation, dry skin, skin cancer, nausea, vomiting, diarrhea, then maybe arrhythmias from, like Tosse the point is maybe QT interval prolongation, QT interval prolongation, then your garlic breath. Garlic breath, because you can oxidize that arsenic to arsenic of trioxide. Arsenic trioxide is what is responsible for the garlic breath of acetone, of of arsenic poison. Okay. Uh, uh, Dr. Zuliat, Dr. Zuliat, are you there? Okay. Dr. Princess, do you want to try?
Let me try.
Okay, just try.
A 27-year-old man is brought to the emergency department due to confusion. His roommate says that he has been binge drinking for the last 5 days and probably has had very little to eat. The patient's medical history is significant for alcohol-related seizures one year ago. He had been sober until 2 weeks ago when he started drinking again. The patient's past medical history is otherwise unremarkable. On examination, he responds to voice but does not follow commands. Finger stick glucose is 35 milligrams per dl, and urine is strongly positive for ketones. Suppression of which of the following is the primary cause of this patient's hypoglycemia?
Okay. So I remember I've said something wrong, so I'm going to correct myself with this question. Yeah. So, Dr. Princess, there's somebody that have taken alcohol and suddenly the person became hypoglycemic and the person is having ketonuria. So, let me just remind you of something. Do you remember when we are talking about alcohol causing increased level of NADH relative to NAD plus? Do you remember that area when we're talking about NADH more than
Yeah,
NAD plus? Okay.
yeah,
Do you remember the changes,
okay.
the four changes it
Yeah,
causes?
gluconeogenesis.
Exactly. You remember that, impairment of gluconeogenesis is one of them. Oh, you,
Yes,
you you said the answer. You said the answer yourself, right? I think you
yes,
said
A.
that
Yeah.
exactly. Yeah. So gluconeogenesis is the answer. So that is exactly what is happening here. This person is taking alcohol, and alcohol is something that gets metabolized by the alcohol dehydrogenase enzyme. You remember that there are two things that metabolize alcohol. The final step you are getting to is formation of a carboxylic acid. So you take alcohol to an aldehyde, then from an aldehyde to carboxylic acid. So alcohol, let's say we are looking at ethanol now. Ethanol will get acted upon by an alcohol, dehydrogenase. So it will oxidize it to ethanol. So ethanol will be acted upon by an aldehyde dehydrogenase. It will also oxidize it to ethanoic acid. Now, those steps, they are oxidizing process, and oxidizing process utilize NAD plus. So that means that you are going to convert all your NAD plus to NADH because you are using them to oxidize, alcohol. So the ratio of NADH to NAD plus is going to increase. That has
Increase. Yeah.
some implication. So some of the implications we are seeing there, we can see ketone body formation. Yeah, that's one. It can also bring about hypoglycemia. But the first one that we should remember is lactic acidosis. So I made a mistake when I was talking about the lactic dehydrogenase enzyme. Now, whenever NADH is more than NAD plus, it favors formation of lactic acid. Why? Because your lactic acid dehydrogenase enzyme activity kicks in. It will convert all your pyruvate to lactate. Why? The rationale behind that is to use NADH that is accumulating, convert it to NAD plus, so that NAD plus can go to glycolysis and be forming NADH to generate more energy. That is just what is there. My point there is that whenever you are converting pyruvate to lactate, you are using NADH. That is it. You are using NADH. You are using NADH, and you'll be generating NAD plus in the process. So the other step that happens is hypoglycemia. Now, why is hypoglycemia happening? We have to go back to the TCA cycle to understand that. So hypoglycemia will happen because now I hope you can see this reaction of malate getting converted. Why? This is not the there's a particular place that the shoulder harrow.
Hi, Dr. Lavali.
Dr.
Hello, good
Francois, I'm
evening.
with you.
Please, are you recording this?
Yes, I
I just
have.
want to
I have.
Okay, thank you.
You're welcome, Dr. Francois. Um, Sorry guys, I'm trying to look for that particular pathway so that we can see what I want to show. What I want to show us.
Is page 72.
72. Okay, you already know the pathway I'm talking about. Yeah, this is it. I think this is it here? No, it's not here. Okay, yeah, it's here. Yeah. So one thing I want you guys to know here is that conversion of malate to oxaloacetate. What do you guys think that generates? Conversion of malate to oxaloacetate. What does it generate? Hello? Do we know what that generates? Malate to oxaloacetate. Hello? Have we talked about the TCA cycle?
Yes, we have.
Ah,
Yes, we
we have
have.
to remember those. The thing is, we don't have to memorize everything about this TCA cycle, but there are some salient stuff that we need to know. Like when you are converting isocitrate to alpha ketoglutarate, you generate NADH. Once you are converting alpha ketoglutarate to succinyl CoA, you generate another NADH. Once you are taking this succinyl CoA to succinate, you generate GTP. When you are taking succinate to fumarate,
FADH.
you generate what? FADH2. Yes.
FADH.
When you are taking malate to oxaloacetate, that's where you generate the last NADH. Very important. Now, so it means that when you are having a lot of NADH, do you think malate will be converting to oxaloacetate? Do you guys think that reaction will be occurring when you're having a lot of NADH in your circulation?
No.
No. So the reverse will be happening. Oxaloacetate will be coming. So NADH will be using, oxaloacetate will be using NADH to convert itself back to malate. So you'll be having a lot of malate in circulation. So we're having reduction in the level of oxaloacetate. So if there's a drop in the level of oxaloacetate, one thing about oxaloacetate is that there's an enzyme that we call um, phosphoenol pyruvate carboxykinase. Phosphoenol pyruvate carboxykinase. That enzyme catalyzes the conversion of oxaloacetate to PEP. So you guys imagine that once you are able to form your PEP, you can take the process back upward to form glucose. So that means PEP will be converted to 2-phospho, to 3-phospho, to 1,3, to glyceraldehyde, then to go up to form our glucose. That is the importance of oxaloacetate being converted to PEP through the action of PEP carboxykinase. But if this guy has accumulation of NADH, that means that you have conversion of your oxaloacetate to malate. So there's reduction in the level of oxaloacetate. There's reduction in the level of conversion of oxaloacetate to PEP. There's no PEP to drive gluconeogenesis. That is why people with alcohol can suffer hypoglycemia. Okay. So I think we understand that process now.
Yes.
So the hypoglycemia in them is not due to the fact that you cannot break down glycogen. No. Oxaloacetate is not related to glycogen breakdown. No. No. But it is important in gluconeogenesis. That is it. All right. So well done, Dr. Princess. Well done. Um,
Mm.
Dr. Uh, okay, I think Dr. Princess, Dr. Precious, Dr. Precious, I see you. I see you.
So I can't read now. Sorry.
Okay, but hope you are listening, Sha. Hmm?
Yes, I am. I'm
Okay,
listening.
okay. Dr. Abisola. Okay. Dr. Adiola. Okay, so Doctor, that means I have to go back to. Is Dr. Adu there? Dr. Adu?
Hello, can you hear me?
Yes, I can.
Yes, Chief. Hello.
Okay,
Okay.
okay, nice one, Dr. Adu. I'll call you next. So, Dr. Abisola, you take this.
A 6-month-old boy is brought to the emergency department by his mother because of recent onset of vomiting, irritability, and jaundice. The infant was born at term and has been healthy until the until the onset of these symptoms. All of his vaccinations are up to date. Up to date, he has been breastfed exclusively until 1 week ago when cereals and fruit juice were introduced into his diet. Further evaluation reveals hepatomegaly and abnormal liver function test. Which of the following is most likely to be deficient in this patient? Okay. This should be okay. All right. So the baby was fine until they introduced cereals and fruit juice. So that has to do like with like fructose metabolism.
Okay.
So that would be more severe. Adulis B is the hereditary fructose intolerance. C is fructokinase. That's for the essential fructosuria. D is galactokinase.
Mhm.
E is, I think the answer is D.
D. Okay, so Dr. Abisola, let me just expose you to the clincher there. So the person is taking fruit juice. You know, it is that fruit juice that is causing the problem. They started introducing fruit juice, and the person started having this problem. So, so what is it? Fruit juice.
I
Hmm?
E
No. Okay, let's start. What is the carbohydrate that is in fruit juice?
fructose.
Fructose. Fructose.
And
So that means that, and this person is having vomiting, the irritability, the jaundice. So that means that this is a severe form of fructose problem. This is the
Adulis
hereditary. This is what?
still Adulis B. Is it still hereditary?
Yeah. So this is Adoles B. You can see that is Adoles B.
I'm
So
mixing it up. Is there a difference between what's the difference between this question and the question Dr. Kenneth
yeah.
took?
Thank you. So the one Dr. Kenneth took was asymptomatic. They said that person was asymptomatic. The person didn't have this vomiting and jaundice. So the person have this vomiting, jaundice, irritability. But the question they were asking there was not the enzyme that was deficient. They were asking us why, what is the enzyme that compensates for the deficiency of the enzyme that was deficient? So the enzyme that
That's
was
it.
deficient is what? Hello?
That's the of having.
Yeah. So The enzyme that was deficient was fructokinase. The enzyme that compensates for that is hexokinase. So, but here, this person is symptomatic. That means that is more severe. That means that fructose 1 phosphate is actually accumulating. So, what do we need to convert fructose 1 phosphate to DHAP and glyceraldehyde? We need aldolase B. So, if aldolase B is deficient, the person accumulates fructose 1 in the liver, in the kidneys, and brings about all these things. Do you get it now, doctor? So, you know, when you want to separate this galactokinase and this fructokinase, what you just need to do, okay, look at what they are giving that child. Is it breast milk? If it's breast milk, you know that that's likely to be your galactose. If it's fruit juice, or sucrose, that's likely to be, a fructose problem, because fructose is one of the monosaccharide that is present in sucrose. So that's the way you guys look at it. Yeah. So, Dr. Abisola, do you get it now?
Where is E found?
Where is B?
Oh, E.
E. E is another thing, alpha glucosidase. That is all these glycogen storage disease.
So A is galactosemia that starts from like birth.
Yeah, so A is severe galactosemia. Yes, A is severe galactosemia. Yeah.
Thank
Do you get it now? So D, because in A, the person will be having accumulation of galactose 1 phosphate. And we've said it that when you have accumulation of a molecule that is phosphorylated, it accumulates. Do you understand? So galactose 1 phosphate will accumulate in the presence of galactose 1 phosphate uridine transferase deficiency, because you cannot convert your galactose 1 phosphate to glucose 1 phosphate in the absence of this uridine transferase. Do you get that, Dr. Abisola? Hello? Hello? I think maybe our network. Um, are we still with me? Or maybe it's my own network?
I'm still.
Okay. I think it's our network. So that's the difference. So someone that has galactose 1 phosphate uridine transferase deficiency, they have accumulation of galactose 1 phosphate. You cannot take it to glucose 1 phosphate. So galactose 1 phosphate accumulates and causes cataract, causes jaundice, irritability, and all those things. So that's like the equivalent of aldolase B deficiency for fructose. Okay. So that we can move. All right. So we can use the knowledge of what we have been explaining to also answer this question. Dr. Adu.
Yeah, good evening, Chief.
Good evening, Dr. Adu.
So, a 64-year-old man comes to the emergency department due to severe abdominal pain, nausea, and vomiting. Medical history is significant for hypertension, MI, and heart failure with reduced ejection fraction. The patient does not use alcohol but smokes half pack of cigarettes daily. Temperature is 7.6. Blood pressure is 160 milliliters of mercury. The pulse is 116 per minute and irregular, and respiration of 24 per minute. The abdomen is soft, mildly distended, and mildly tender without rebound or gouging. Laboratory results as follows: sodium of 136, chloride of 96 millimeters per mercury, molecular equivalent per liter, and bicarbonate, is low. So arterial blood gas of 7, pH of 7.3, PaCO2 of 32, and lactic acid of 6.2, which is high. CT angiography of the abdomen reveals an occlusion within the proximal superior mesenteric artery. Decreased activity of which of the following enzymes best explains this patient's acid-base disorder? Sorry, I've even lost track of the question.
Yeah, it's a long history actually. Clinically oriented
Okay,
question must visit.
sorry, let me see the option again, please, because I've not even gotten the diagnosis. Please, let me go back to the options. Okay, so CT angiography of the abdomen reveals an occlusion within the proximal superior mesenteric artery, decreased activity of which of the following enzymes. Okay. Okay. Enolase, lactate dehydrogenase. Okay, so but lactic acid is Aisha. Okay. Pyruvate dehydrogenase and pyruvate kinase.
So what do you think? You look at that lactate. You know that
I
lactate.
know it's having but it's
Yeah.
high. It's
So what do
pretty
you
high.
think? What do you think can cause?
So okay. So whatsoever that would make lactate to be high, so more likely to be a deficiency of this pyruvate dehydrogenase.
Exactly. It's due to deficiency of pyruvate dehydrogenase. So it means that that stuff cannot go to TCA cycle. So this person is having
Yes.
heart failure, with reduced ejection fraction. So that means that the amount of blood that we are pumping out is very low. So oxygen level too will be low. So that means that this guy has to follow an aerobic pathway to function. So that is why all the pyruvate,
Okay. Yeah.
you get it now. So all the pyruvate to be shunted to lactic acid. So that's why lactic acid is risen rather, it's so high, 6.2. Now, they're now saying which of the following enzyme activity is reduced. So, and I mentioned it that your pyruvate, okay, I don't think I said it, but pyruvate dehydrogenase is known to form like to couple your glycolysis with TCA. That's what it does. It links your glycolysis to
Yes.
TCA, so that you can have progression from glycolysis to TCA. But we've said that whenever there's no oxygen, you cannot do TCA cycle, you cannot do electron transport chain or oxidative phosphorylation. So TCA doesn't even exist in the picture. So if TCA doesn't exist, what is making that is because of pyruvate dehydrogenase, because it is a enzyme that is required to convert our pyruvate to acetic CoA that enters the TCA cycle to combine with oxaloacetate. So pyruvate dehydrogenase is what you pick. Your pyruvate carboxylase will help you form oxaloacetate, fine, but it's not driven towards gluconeogenesis to make oxaloacetate available for gluconeogenesis. That's what is majorly in it doesn't it's not concerned with the oxygen status, if the oxygen is there or not, no. But what is actually concerned about oxygen status is what will make our glycolysis progress to TCA. And what is the enzyme that is doing that? Your pyruvate dehydrogenase. Okay.
Hi, Dr. Babawale.
Yeah.
Sorry, I think you mentioned it, but I missed it. When does it go through the alanine, pyruvate alanine pathway?
Yeah. So
When does it?
when there is this deficiency, pyruvate dehydrogenase deficiency, it can go to that pathway forcefully. Forcefully. So it will,
Okay.
let me show you. So that is why someone with pyruvate dehydrogenase deficiency can have accumulation of alanine and accumulation of lactate, because those are the only two pathways that are viable, for pyruvate to move. So let us see it here. So this is it. You can see it here. Pyruvate dehydrogenase. You can see shunted to lactate and alanine. Can you see it, Dr. Kenny? So
Yes, I can.
yeah.
Thank you.
So I said the reason why it doesn't go to oxaloacetate is because if you have pyruvate dehydrogenase deficiency, you cannot form acetic CoA. Acetic CoA is a coenzyme that stimulates formation of oxaloacetate. Do you see that, Dr. Kenneth? You can even see the arrow.
Yes, I can see
You
it.
can see acetic CoA stimulating PC to
Mhm.
oxaloacetate. So that means that if someone have pyruvate dehydrogenase, they cannot, of course, form acetic CoA. There is no acetic CoA to stimulate PC to form oxaloacetate. So that means that the only two pathways that can go is lactate and alanine. So that's why both of them accumulate and they cause the neurologic manifestation. Yeah, so that's
Okay.
it. But here is actually a response to hypoxemia. Hypoxia. Mm. So it's not actually due to the deficiency of that enzyme. It's just in response to hypoxemia. So you need oxygen to also make your pyruvate dehydrogenase, enter your TCA cycle. So if there's no oxygen, there's no need to go to the TCA cycle. So in the absence of oxygen, you don't go to the cycle, you just stop at lactic acid to be, generating the energy through the anaerobic mechanism that does not require oxygen. So, okay.
Mr. Subale,
Hello?
Mr. Subale,
Yes, Dr. Precious.
yes, please. I don't understand why it cannot be. Why the answer is not pyruvate kinase? Since
No,
like that's the
no.
normal pathway for
Okay.
pyruvate, sort of.
Okay. So let me show you. Don't
So
don't
if
don't
it's
don't
okay,
don't don't look at this kinase of a thing. You get confused. What pyruvate kinase actually do is to convert um phosphoenol pyruvate to pyruvate. It's not moving pyruvate forward. Do you get it? Let me show you. Dr. Precious. It's like that name doesn't actually fit what it does. It converts phosphoenol pyruvate to pyruvate. That is what it does. That's the last step at the glycolytic pathway. Dr. Precious, are you with me?
yes, I'm with you. Okay, okay. I think I get now. How was I thinking it's for conversion to acetylcholine?
No. Conversion to acetylcholine is dehydrogenase. Okay, I think it's clear now. It's
Okay,
dehydrogenase.
okay.
Acetylcholine rather, not acetylcholine. All right. So Dr. Precious, can you read now?
Okay, yes, let me read. A 35-year-old man comes to the office with progressive worsening fatigue and shared with dark urine and back pain. 2 days ago, the patient had some large flat beans brought home by his wife after a business trip to Egypt. Physical examination shows jaundice and pallor. Laboratory results reveal a hemoglobin level of 8 grams per dl. Further evaluation reveals the efficiency of an enzyme involved in the conversion of glucose phosphate to ribulose 5-phosphate. Okay. The substance generated during this conversion is necessary for which of the following biochemical processes? My answer will be okay from glucose 6 to ribulose 5-phosphate. Is
Mm-hmm.
this glycolysis pathway? Yeah.
No. Uh, that
I've
means
never
did
seen.
you
I
did
don't
you
know what
uh
ribulose is. Though.
that means you did not start this discussion with us. You did not start.
No, no, no. I just joined like some minutes ago.
Mm, ah, okay. Let me see if you can remember. I'm sorry, Dr. Precious. I'm going to move it from you. I'm so sorry. You are going to do the next question.
No problem.
So,
No problem. No problem.
Dr. Nwako, Dr. Nwako. So, what are we going to generate from this conversion? Is Dr. Nwako there? Okay, Dr. Nwako is not there. Dr. David, Dr. David. Conversion of glucose 6 phosphate to ribulose 5 phosphate. What are we generating?
Can I reply?
Yeah, anybody, please, anybody. What are we
Is
generating?
it NADPH?
We are
DPH.
generating NADPH. We are generating NADPH. This is talking about the HMP short. So, Dr. Precious, before you came, we talked about the HMP short or the pentose phosphate pathway. It takes glucose 6
Okay.
phosphate. It takes glucose 6 phosphate to 6-phosphogluconolactone. That process is going to generate NADPH. 6-phosphogluconolactone is going to go to ribulose 5-phosphate. That also generates NADPH. You can convert your ribulose 5-phosphate to your fructose 6-phosphate. That reaction is catalyzed by transketolase. I think you need to see an image so that you can understand it. So I'm going to go again to show us that image because of some of us that didn't join early. So now the question is now, what is the application of NADPH? That is what the question is now asking us now. What is the application of NADPH? Um, where is this stuff? Okay, is it so Dr. Precious, can you see it now? You can see your glucose 6
Yes, I can
phosphate.
see it.
going to 6-phosphogluconate. You can see it, 6-phosphogluconate. Mm. That is what glucose dehydrogenase is doing. G6PD, that is what it is doing. Mm. It is converting glucose 6-phosphate to 6-phosphogluconate. And in the process is generating NADPH. You can see the arrow, NADP plus going to NADPH. Same thing is going to happen to 6-phosphogluconate. You are generating NADPH and you are generating ribulose 5-phosphate. I want you to remember that this reaction is oxidative reaction. You are oxidizing. Anytime you are using NAD plus or NADP plus to catalyze something, you're oxidizing. So you're oxidizing to this guy. Now, ribulose 5-phosphate is going to get isomerized to ribose, not ribulose again, ribose 5-phosphate. So that ribose 5-phosphate is getting converted to fructose 6-phosphate. Now, Dr. Precious, what is happening here is that you are taking back this ribose 5-phosphate to fructose 6-phosphate so that you can continue your glycolysis. You remember that conversion of glucose 6-phosphate to fructose 6-phosphate is one of the steps in glycolysis. You remember?
Yes, I remember.
So this whole HMB shunt is just like a branching. They are just branching. Glucose 6-phosphate is just branching that pathway to just synthesize NADPH so that it can do some things for the body. That's just it. At the end of the day, it's still going to go back to fructose 6-phosphate. So you must remember this. It goes back to fructose 6-phosphate through the activity of transcatalysis. Mm? Through the activity of transcatalysis. Yeah. So now the next thing is now to know the activity of NADPH. So what does NADPH do? We should remember one of them. We've talked about one of them today. Do we remember? I mentioned something. What?
Yes.
What?
It keeps glutathione reduced.
Exactly. It reduces what?
Glutathione.
Exactly. So it helps us produce reduced form of glutathione. That's one, which is an antioxidant that helps to protect our red blood cell from oxidative stress. So that means that anybody that has G6PD deficiency, you cannot produce NADPH, and there's no way you can reduce glutathione to reduce form. So in the absence of reduced glutathione, you cannot protect red blood cells. That is one function. Very important. The second function is that it helps in the metabolic process of the cytochrome P450 system. So the way they metabolize drugs and all those things, your NADPH is involved in that. The third one is it's important in anabolic processes to synthesize things. What are these things? Your fatty acids and your cholesterol. Very important. Fatty acid, cholesterol synthesis. It helps. So that is why it's abundant in cells like the liver, the adrenal cortex that produce steroid hormone because they need fatty acids. So steroid hormone synthesis, fatty acid synthesis, and cholesterol synthesis, you need your NADPH. And you can only get that if you have glucose 6-phosphate dehydrogenase working. So we've talked about the cytochrome P450. We've talked about producing reduced form of glutathione. We've talked about anabolic process which involves synthesizing fatty acid, cholesterol. Then the last one is um,
Respiratory burst.
respiratory burst. Thank you, Dr. Kenneth. So when we say respiratory burst, that means we are saying ability to generate NADPH that can get oxidized. So you need to oxidize your NADPH because oxidative burst involves NADPH oxidase. So you oxidize your NADPH to generate superoxide. So superoxide are available so that you can destroy microorganisms, bacteria. Very important. Thank you, Dr. Kenneth. So respiratory box because you need to generate NADPH, you know, that can get oxidized through NADPH oxidase. Then glutathione reductase, synthesizing molecules, then cytochrome P450 system. So with what we have said, so what is the best answer to pick here, Dr. Precious?
B.
Fatty acid synthesis. That is it. Okay.
That's what I said. B. Can you hear me?
Yes, you are correct. You are correct. You are correct. So this guy is having G6PD. You can see this G6PD deficiency, dark urine, back pain, fatigue, pallor, jaundice, G6PD deficiency. Yeah. So, Dr. Abisola, Dr. Abisola, I want to reinforce this particular stuff. Okay. Well, because we've not done it very well, but just talk about it. Dr. Abisola, are you still there?
Yeah, I'm here.
Okay.
A 5-day-old term newborn is brought to the emergency department for multiple episodes of emesis. The breastfed infant has been having fever, wet diapers over the last 2 days. Vital signs show tachycardia, tachypnea, and hypotension. Physical examination shows an ecteric lethargic baby with a sunken fontanelle, dry mucosal membrane, and hepatomegaly. A blood culture is drawn and empiric antibiotics are initiated. Hematologic studies shows leukocytosis with pandemia. Serum studies showed hypoglycemia and elevated transaminases. The ammonia level is normal. Newborn screening is pending. Preliminary results from the arterial blood culture shows gram-negative rods. The infant is placed on special formula and gradually improves over the next few days. Which of the following steps in metabolism is most likely impaired in this patient? So this is the severe galactosemia.
Yes. You see that you have mastered it now. This is the severe form of galactosemia. That's very correct. So, um, sorry, I think I've missed up picking this thing. Ah, God. Ah,
Yes,
okay, okay.
but
You know the step. Do you know the step?
step lactose.
I'm sorry about this. Oh, God. I need to take another extra image. So, I think I left that. So, what's the enzyme that is deficient there?
The gout. What's it
Exactly,
called?
exactly. The gut, the gut. So, what does gut do?
Yeah, I cannot remember now.
Like, so the name gut, galactokinase.
Gala,
No, it's not galactose. That's why I don't use acronym. Galactose 1 phosphate uridine transfer. That's what it should be. Does that go?
yeah,
Gut. Galactose 1 phosphate uridine transferase. So
so it will be
yeah. So that means that the first reaction is conversion of galactose to galactose 1 phosphate. That is catalyzed by galactokinase. Then that galactose 1 phosphate is now acted upon by galactose 1 phosphate uridine transferase, converting it to glucose 1 phosphate. You get it? So, in the absence of that GOT, that uridine transferase, you have accumulation of galactose 1 phosphate trapped within the liver. That is what is causing all those things. Now, the clean charts I just want you guys to pay attention to, apart from being breastfed, is that they will also tell us that the person has, you know, E. coli sepsis, very important. So the E. coli sepsis that they are predisposed to is what is explaining the leukocytosis and the pandemia. So you are seeing a lot of immature form of the white blood cells and increase in the total white blood cell count, leukocytosis. And they told us that they did the culture and it, grew the gram-negative rods. Example of a gram-negative rod is E. coli. So E. coli sepsis is common in people with the severe form of galactosemia. We should not forget that. E. coli sepsis is one of those things. So we can see cataract. Cataract is there because there's, increased accumulation of galactose 1 phosphate, increased accumulation of galactose, and galactose can get converted to galactitol. So this galactitol is very toxic to the lens. So it's accumulated within the lens and brings about the opacity, which causes um, the cataract that they can have. So you can have someone can have cataract both in the galactokinase deficiency as well as the GOT deficiency because of the activity of galactitol. So we should not forget that. I think Dr. Babarinde is still going to shed more light on the galactose pathway. So let's do this one too. Um, is there anybody I've not called to? Dr. Chidima. Dr. Chidima, are you there?
I'm available now. Good evening. Sorry.
Okay.
Yes, sir.
back after her.
Okay, all right. So someone said she's available. Is that Doctor?
3-year-old, yeah,
Okay,
elder man is recently migrated to the US. Came to the outpatient clinic when asked, he said he doesn't have medical problems, but his mom told him that he was born with a problem metabolizing sugar. He has no dietary restrictions and regularly eats vegetables, fruits, meat, and processed food. Urine samples repeatedly positive copper reduction tests, but glucose oxidase dipstick is negative, referring enzymes is most likely to be defective in this patient. Fructokinase.
yeah, exactly. So they said 23-year-old apparently healthy. So this person is healthy, and they said his mother told him he was born with a problem metabolizing sugar. So he takes vegetables, fruit, meat, processed food, and the person is still all right. And they did urine test. It was positive for the copper reduction. So that means that there's a reducing sugar there. So glucose is a reducing sugar, galactose is a reducing sugar, fructose is a reducing sugar. So, but glucose oxidate dipstick testing is negative. So the dipstick test for glucose is only specific to glucose. It doesn't detect fructose. So said, which of the following enzymes is more likely deficient in this patient? So for the person to be asymptomatic and still be taking fruit and other things, and they told us that he has a problem metabolizing sugar and is a positive test for reducing sugar. So it's likely to be fructose that is accumulating. It cannot be any other thing. So if it's galactose, it will have some symptoms like cataract. It won't be asymptomatic. Might not just be severe as galactose 1-phosphoryluridae transferase deficiency. So if he has a problem with lactase, he will not be able to metabolize, you know, lactose from milk, and he'll be having, lactose intolerant. Anytime he takes milk and anything, he has diarrhea. So the person will not be, you know, asymptomatic. So the only condition that the person can be asymptomatic and have a problem metabolizing sugar is fructokinase deficiency. Okay. Um, so guys, I'm not going to call anybody for this because the screen is not well displayed. So I'm going to read it, and we are just going to mention the answer. So um, a mutation in a non-coding DNA sequence is believed to affect expression of the gene coding for a specific fetal enzyme. Liver and bone marrow cells from the fetus and its parent are obtained. Which of the following is the best method to determine if this gene, that is the gene coding for that fetal enzyme, is transcribed in cultures of the isolated cells? So what test are we going to do to determine if that gene is transcribed? Anybody? What test are we going to do to determine if the gene is transcribed?
Total
Last
blood.
time.
Hello, I'm sorry, this thing is
So,
is is the
not
other way
blood.
around. The
The what?
the the
Yes, I know.
projection.
I know. That's why I'm
South.
Oh,
reading it. So that's why I'm reading it.
okay. Thank you.
Yes.
Small drop.
So
Southern.
Northern.
the
The
what?
southern.
Eh?
Northern.
Northern.
Northern. So why are we picking
Northern.
northern? Why are we picking northern?
Hmm. Because a
Just
transcribed
transcription.
gene is RNA.
Exactly. A transcribed gene is RNA. So that's what will be
Hmm?
identified by, you know.
Dr. Babali, are you breaking? Is it me or can everybody hear him clearly, or is it just me?
I can hear him.
And that was my note. Yeah, thanks.
Okay. Yeah, so Dr. Chidima, I think Dr. Chidima should should be the next person now. Dr. Chidima.
Okay. Jesus. Okay, yeah. A 52-year-old man is being evaluated in the emergency department for abdominal pain associated with watery diarrhea. His symptoms have been progressive over the last month. He says that he is depressed and often has difficulty remembering things. The patient has a 20-year history
of alcohol use disorder. On examination, he appears disheveled. A pigmented scaly skin rash is present on the malar distribution of his face, neck, and back of his hands. The rash has been present for several months and worsens on exposure to sunlight. It is determined that the patient's symptoms are secondary to lack of specific nutrients. Which of the following enzymes is most likely to be directly affected by this patient's nutrient deficiency?
So, Dr. Chidima, what do you think is your diagnosis? Don't just look at what the person is having. Marry them together. What do you think can explain all those things? The the diarrhea, the dementia, the rash.
It's not coming together in my head.
Like the three Ds of something.
Dementia.
Three Ds, dementia. That individual will have this rash on their neck. The broad collar rash, or the Kasai necklace, or whatever do we call it.
Mm, mm, mm.
Yeah.
Well, Wale, that one, na hint.
Oh, I know Sabi Agu, because
Elagra.
yeah, pellagra. So Dr. Chinima, it's pellagra.
Pellagra.
Don't forget the three Ds of pellagra: dermatitis, that is rash, the diarrhea, and the dementia. Hmm? Sometimes they might not put dementia out there. They might just watch out for neurologic problems. So, but usually it's dementia, dermatitis, diarrhea. The three Ds of pellagra, and the vitamin that is implicated there is vitamin B3, right? Vitamin
Yes.
B3, which is also known as niacin. Niacin.
Yes.
So one of the ways by which someone can have that is maybe someone is using isoniazid, because to synthesize that niacin, you need vitamin B6 and vitamin B2. So if somebody is on isoniazid, they have vitamin B6 deficiency, and in the process, they also have vitamin B3 deficiency. Or someone has Atnop disease, in which they cannot reabsorb tryptophan from the kidneys and intestine. So tryptophan is essential for formation of that niacin. So the absence of that tryptophan, they cannot have niacin formation, and they'll be palagric. So we have some other causes, but let us stop there. So now the question is, now you have figured out the diagnosis. You already know the vitamin that is deficient. So the next thing is now, knowing the enzyme that is dependent on that vitamin. So what do you think? Which one do you want to go for? Which one do you think? Dr. Chidima, are you still there?
Yes, I'm here.
Okay.
Okay. I'll pick option C.
Yes. So I will agree with you. You see, one thing about all these dehydrogenase, except succinate dehydrogenase. Succinate dehydrogenase is the only one that requires vitamin B2, riboflavin, succinate. That's it. Once it sees riboflavin, it is done. Mm. But some other ones like pyruvate dehydrogenase, remember that pyruvate dehydrogenase requires like five. The first four: vitamin B1, vitamin B2, vitamin B3, and vitamin B5. There's no vitamin B4. So the first four vitamins, vitamin B1, 2, 3, and 5, pyruvate dehydrogenase requires them. I want to use this opportunity to also tell you that it is not only pyruvate dehydrogenase that requires those coenzymes, those exact coenzymes. Your alpha ketoglutarate dehydrogenase also requires them. So your alpha ketodehydrogenase complex and pyruvate dehydrogenase complex requires same cofactors, just like isocitrate dehydrogenase. So your isocitrate dehydrogenase, your pyruvate dehydrogenase, your alpha ketoglutarate dehydrogenase, they all require, similar enzymes, and one of them is vitamin B3. Succinate dehydrogenase is an exception. It only requires vitamin B2. Hmm. Do you get it now, doctor?
Yes, thank you.
Yeah. So Dr. Moravia, I think it was Dr. Moravia that talked the other time. Chief, or it was Dr. David. Was it Dr. David's voice that I heard? They both sound similar, so I don't know. Okay, so I don't think Dr. Moravia is here. Okay, Dr. Moravia is not here. So Dr. David is here. Or Dr. Henry. Dr. Henry, are you there? Okay. Have I called Dr. Miriam today? Dr. Miriam, have you spoken today? Dr. Miriam.
I'm here. I'm here.
Okay. Dr. Miriam, so I'm just going to check this one.
Which of the following reactions directly synthesizes this cofactor? A 43-year-old man prospecting for gold in Arizona becomes stuck in the desert after his truck breaks down. He brought a large supply of water with him, but only a few granola bars as food. After 3 days, he is able to flag down a passing vehicle and obtain transportation to the nearest settlement. During this ordeal, his liver begins to synthesize large quantities of glucose from source molecules such as alanine, lactate, and glycerol. As part of this process, phosphoenolpyruvate is formed from oxaloacetate in a reaction that requires a specific nucleoside triphosphate as a cofactor. Which of the following reactions directly synthesizes this cofactor?
Okay.
Please, can you scroll back to the question?
Okay.
What are you even talking about? Phosphoenolpyruvate is formed from oxaloacetate that requires a specific okay. Please, can you scroll down? I think that the answer is
Okay. Sorry, I did not say anything. So they said a specific nucleoside triphosphate. Do you remember that we've been mentioning so many things today with respect to the T cell cycle, what they produce? We mentioned
yeah.
NAD, we mentioned NADH, we mentioned FADH2. So there's something else that we've not mentioned. Though we mentioned it, but do you remember? So when we said NADH,
ATP.
no,
GT,
no, no, it's not ATP. Hmm? Somebody is saying it. Somebody is
GTP.
GTP, exactly. So GTP is what you produce. GTP, 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 GTP. So
Okay.
GTP. Don't forget. So GTP. That GTP is also involved in moving our phosphoenol, moving our oxaloacetate to phosphoenol pyruvate. So when we're talking about gluconeogenesis, then we said oxaloacetate moves to phosphoenol pyruvate by the activity of phosphoenol pyruvate carboxykinase. It uses GTP. It uses GTP. Okay. So now, knowing the step that generates that GTP is now the issue now. So what step do you think generates the GTP? We figured out
It's
the
from succinate CoA to succinate. That's
exactly.
E.
That is it. That is it. So oxaloacetate joins with that's all about the T cell cycle. Oxaloacetate joins with acetyl-CoA to form citrate. That doesn't generate anything. So it is when citrate is now going to acetyl citrate, that's where you generate your first NADH. You generate your first NADH from citrate moving to isocitrate. Isocitrate moving to alpha ketoglutarate, you generate your second one. No, no. Citrate moving to isocitrate, first one. Isocitrate moving to alpha ketoglutarate, second one. So citrate moving to isocitrate first NADH. Or isocitrate moving to alpha ketoglutarate, you generate the second NADH. Now, no, I think there's a mistake there. What are we saying?
Isocitrate
No,
to alpha
yes,
generates the
that's the
first
first one.
NADH.
Yeah, thank you about that. So isocitrate going to alpha ketoglutarate is the first, then alpha ketoglutarate to succinyl CoA is the second. So the way we can just learn it is just know that that energy forming process starts from isocitrate. So it starts from isocitrate, not citrate. So isocitrate dehydrogenase form the first one. So when isocitrate converted to alpha keto form the first one, alpha keto to succinyl CoA we form the second. Then succinyl CoA to succinate, you form your GTP. Then our succinate to fumarate, you form our FADH2. Succinate to fumarate, FADH2. Then fumarate to malate doesn't generate anything. Malate to oxaloacetate generate the last NADH. So at the end of the day, if one molecule of acetyl-CoA enters this cycle, you have formation of 3 NADH, 1 FADH2, 1 GTP. But at the end of the day, you are going to have 2 molecules of acetyl-CoA entering because you're having 1 glucose, 6 carbon. 1 glucose will form 2 pyruvate because pyruvate is 3 carbon. So we are going to have 2 pyruvate. So each pyruvate will form 1 acetyl-CoA. So at the end of the day, you are going to have 2 acetyl-CoA. So 1 acetyl-CoA is going to form this complete cycle. So that means that 2 acetyl-CoA is going to form product of this cycle twice. Do you guys get what I'm saying?
Sorry, can you go over that again? The last part.
Okay. So if you want to know the total number of NADH or something that's generated from the cycle, what I'm saying is, you know that everything starts from glucose. Remember that glucose is 6 carbon and glucose forms pyruvate. Pyruvate is 3 carbon. So that means that glucose are splitted somewhere. You remember the splitting point at fructose 1,6 biphosphate. That's where it splits. So that means that 1 molecule of glucose will form 2 molecules of pyruvate. Do you get that, Dr. K?
Yeah.
Yeah.
Thank you.
So 1 molecule of pyruvate now forms 1 molecule of acetyl-CoA. So it is 1 molecule of acetyl-CoA that enters the cycle. So if 1 molecule of acetyl-CoA generates 3 molecules of NADH and 1 molecule of FAD2 and 1 molecule of GTP, so that means that 2 molecules of acetyl-CoA or 1 molecule of glucose is going to generate times 2 of that. Do you get it?
Yes.
So that is how you can calculate.
The
I don't know.
total 80.
Did Dr. Babari they talk about the malate aspartate glycerol 3-phosphate short 2 pathway? Did he talk about it? That you are generating 32 ATP somewhere and 30 somewhere. Did we
He
talk about
mentioned it in passing.
it? Okay, maybe he's still going to analyze it. You guys have to know it.
No, he said it's secondary school stuff that we don't
Second,
need it.
second,
We're bigger than all that.
okay, Chief doesn't want you to bother to talk about it. Well, I don't really think it's huge, yeah, but
Yeah.
but maybe if you see a question, we can just talk about it. It's a little bit, tricky, but maybe we should just ignore it. Let's just ignore it. Yeah. So So as I was saying, so you guys should not forget, succinate CoA going to succinate generate the DTP, succinate to fumarate generate the what's it called the FADH2, and malate to oxaloacetate generate the last NADH. Yeah. So we have answered that question already. Okay. Yeah, this is another very interesting one. I want to know if you have mastered this stuff totally. Now this is where I will know. So let me call Dr. I'm not actually going to say that. I'm not supposed to say that so that I don't put anybody on the spot. Yeah, I don't actually mean to say that. Even if you miss it, it doesn't mean anything. So Dr. Should I call? Okay, let me just call. So Dr. Dr. Adeola. Dr. Adeola. Dr.
Object that you're going to call me.
Ah, so that's it's a very you
Erythroblasts isolated from the bone marrow biopsies of a patient with a natal drugs incubated in a medium containing delivered glucose. Cells are unable to generate any NADPH from glucose metabolism, but can convert fructose 6 to ribose 5, which is required for nucleic acid synthesis. Trifolic enzymes is necessary for the later conversion. Transcriptase.
yeah. So I know it will be like a walk in the park for you. You just
Yeah,
look at it
so
and just
I picked it
relax.
because I know that red cells they don't have the glycolytic pathway, and I know that they use the what's the name for their own um um this thing nucleic acid synthesis. So
Yeah.
you explain it further, sure. But
Yeah.
that's why I picked
Yeah. So
transcriptase.
like they do glycolysis actually, but they cannot do all this TCA and mitochondrion. You need mitochondrion to be doing oxidative phosphorylation and those TCA guys. TCA occurs in the mitochondrion, so they don't have all those ones. So they don't do that. So they just do major glycolysis. Just imagine a cell is not doing glycolysis, the cell cannot exist. So they just generate little energy from that glycolysis. One thing is very peculiar to red cell that I'm supposed to talk about, but maybe I'll just show us that pathway. So we can see that it's going from fructose 6 phosphate to ribose 5 phosphate. So, and we mentioned then that this ribose 5 phosphate is for nucleic acid synthesis. So they're now asking us what is the enzyme that is essential for the conversion of the latter. Now, this latter one is actually ribose 5, not ribulose 5. So you need to take it from ribulose 5 to ribose 5. Then ribose 5 now goes to fructose 6. But that reaction is a reversible reaction. So we said the upper one is a oxidative irreversible, while the lower one, which involves ribose 5 and fructose 6, is non-oxidative and it is reversible. So it can go anyway. So you can convert fructose 6 to ribose 5, and that reaction is catalyzed by transketolate. So you can convert fructose 6 to ribose 5 and ribose 5 to fructose 6 through the activity of transketolase. So what is the coenzyme that catalyzes that reaction? Anybody? The coenzyme that is responsible for that reaction.
B1. I mean,
Vitamin B1. Vitamin B1. Yeah, vitamin B1. So um that is why if you want to, check if somebody has been responding to your vitamin B1 supplementation, you just measure their red blood cell transcatolase. You see that it will be increased. So that is that. Um, okay. So Dr. Kenne,
Hi, an 11-year-old girl is evaluated for blurry vision. The patient was adopted internationally at age 9. She has no history of head or eye trauma or exposure to ionizing radiation. Motor and cognitive milestones have been achieved at the appropriate age. She has a good appetite and does not follow any specific diet. The patient takes no medications and has no allergies. Vaccinations are up to date. Vital signs are normal. She is at the 40th percentile for height and weight. Other than bilateral lens opacities, the rest of her examination is normal. Urine is positive for reducing substances. Deficient activity of one of the following enzymes is the most likely cause of this patient's eye condition. I think she's got cataract. That's the bilateral lens opacities. So I think she's got a form of galactosemia.
exactly.
Yeah, she's got the less severe type. I don't know
Yeah,
what
the
that's
less
called it,
severe type.
benign. Yeah,
Yeah. You can see that the urine is also staining, is also positive for the reducing substances.
reducing substances as well.
Yeah. So
So she's got galactokinase deficiency.
yeah, exactly. Yeah. That's soft. Okay. Doctor, I don't even know who to call now. Uh, Doctor, uh, Doctor David. Doctor David. I know we'll get this one. We've talked about this a lot of time today.
A healthy 34-year-old coal mine worker is trapped underground following partial collapse of an access shaft. Rescue efforts are directed towards clearing the obstructed tunnel, but it takes 2 days to reach him. While being, while being taken to the surface, the miner tells rescuers that he feels dizzy and weak. He had an emergency supply of water but has not eaten anything for over 30 hours. Finger stick blood glucose concentration is 78 mg per day. Which of the following biochemical reaction is most likely responsible for maintaining this patient's current blood glucose level? It's most likely responsible. Okay. So that would be glycogenolysis. Now, glycogen to glucose 1 phosphate.
Are you sure? 2
Okay,
days.
no, sorry.
2 days.
Oxaloacetate of phosphoenolpyruvate.
Yeah. So the reason why that is not correct, what you said earlier is not correct because 2 days, you will have depleted your glycogen stores.
Yeah.
So after 2 days, after 24 hours, glycogen stores is gone. Is gone. So what will help you is gluconeogenesis from the liver and the kidneys. So it occurs in the liver. Gluconeogenesis occurs in the liver, the kidneys, as well as the intestinal epithelial cells. So those three guys, intestinal epithelial cells, the kidneys, and the liver, helps maintain gluconeogenesis. So, and to initiate gluconeogenesis, you need oxaloacetate to go to phosphoenol pyruvate by the activity of the phosphoenol pyruvate carboxykinase. Okay. Um, okay. So, Dr. Adu.
Okay. The following should be removed from this patient's diet. 6-month-old full-term boy is brought to the emergency department with lethargy and vomiting. He was born by uncomplicated spontaneous vaginal delivery and has been growing and developing normally. The patient was breastfed exclusively until 2 days ago when homemade fluid food was added to his diet. He has had no fever or diarrhea, experienced healthy, and he has had no sick contacts. Examination shows a pale, diaphoretic, and ill-appearing infant. Serum glucose is 30 milligrams per DL. Diagnostic testing confirms the aldolase B deficiency. So, which of the following should be removed from this patient's diet? Okay, so aldolase B deficiency. So that should be okay. Uh, uh, okay, hereditary fructose intolerance, right?
Exactly. So that would be hereditary fructose intolerance. That's very correct. So,
So we should remove sucrose from
yeah,
the baby's.
yes. So why are you saying sucrose? Why?
Is disaccharide of fructose and glucose.
Nice one, Dr. Adu.
So since the patient is
Nice one. Nice
so
one.
since the patient is having a okay, all right, thank you, bro.
Mhm. Oh yeah. Yeah. I'm listening, Dr. Adu. Hello?
Yeah, yes, I said disaccharide for glucose and fructose is a
Mm-hmm.
sucrose, and since the patient is having a deficiency of metabolizing, hereditary deficiency of metabolizing fructose.
Mm-hmm.
So, and the only thing containing fructose in all the options there is sucrose.
Sucrose. Yeah. Yeah. Exactly. So that is it. So this person will not be able to metabolize sucrose, fructose. So that means that you don't want to give anything that can release fructose. Sucrose is one of them because sucrose is a disaccharide containing fructose and glucose. So you don't want to give sucrose. Another thing I want you guys to also know that you don't want to give this person aside fructose is sorbitol. So sorbitol, I think that's the next part that Dr. Babarinde is going to move into. So we are going to talk about the sorbitol pathway. So sorbitol can get acted upon by sorbitol dehydrogenase and can be converted to fructose. So you don't want to give them sorbitol, you don't want to give them sucrose, and you don't want to give them fructose. Those three things, very important. Okay. Um, Dr. Miminat.
Okay. Um, a 42-year-old woman comes to the clinic for follow-up evaluation. She has a 15-year history of resting tremor, bradykinesia, and cogwheel rigidity consistent with Parkinson's disease. One of her siblings recently started having similar symptoms. As part of a research study, genetic analysis is performed on the patient and the affected sibling. The results show a loss of function mutation that leads to accumulation of misfolded proteins, which are the following biochemical processes is most likely defective in this patient. Anyway, because I just had like because the question has misfolded proteins, so I'll just go for ubiquitination.
Combination, yeah. So if there is accumulation of misfolded protein, ubiquitination is what should help eradicate those proteins. So you just have to ubiquitinate them. You add this ubiquitinin to them, then you target them for proteasomal damage. So they go to the proteasome and they are degraded. So do you remember any condition that contains misfolded protein, Dr. Mominat? Any condition that we've talked about
Yeah.
associated with misfolded protein? Do you remember any?
Misfolded proteins. Like this there's something like anticipation here. What condition is that? Is it Friedrich ataxia?
I don't think
I
there's
don't know.
no. There's no misfolded protein in federation ataxia. There's one condition
I
that
can't remember.
there's one condition that
Hmm.
that protein is misfolded, so it doesn't get to where it's supposed to go to. So it's supposed to be at the membrane and be allowing something to pass through, but it doesn't. It's
Cystic
misfolded.
Cystic
fibrosis.
fibrosis.
Exactly, cystic fibrosis. You guys remember the treatment for
Oh,
cystic fibrosis? You want to give some drugs.
Castor. Castor.
Exactly. So if you are talking about the ivacaftor, you are trying to insert it to the membrane. If you are trying to uh, take care of the misfolding, like your is it tevacaftor now, or those two guys, those other two guys, those ones are the ones that help you correct the misfolding. While the one that help you to insect the stuff is your ivacaftor. Yeah. So cystic fibrosis is one of them. Uh, this guy is also another one, but we've not done it. Alpha 1 antitrypsin deficiency. So it's also misfold and accumulate with the liver and cause problems. So I hope we are
okay,
not.
what about this question? What do they have in this question? Like aside the
Yeah.
Parkinson's disease,
Mm-hmm. Yeah. So it is.
what is the
What is what?
you know they said that the siblings started earlier, right?
Okay. Yeah. So
Mm-hmm.
this is not actually anticipation. No, you don't have anticipation in Parkinson. I don't think so because I'm
Okay.
not really sure. I'm not sure, but Parkinson is not one of those trinucleotide repeats. So it's not like,
Yeah.
but it might have some. I can't.
No, what I'm thinking is like like this particular question that like Parkinson being a future of another syndrome. Like maybe they just didn't give us the full picture because we don't really need it. I'm just thinking.
Yeah, but this is how Parkinson presents. They have these things, and it
No.
can be it can be a genetic stuff. If because
Okay, okay,
so that is it. So it's a genetic issue.
okay.
So
All right.
yeah.
Thank you.
I wanted to say something there. I wanted to just ask you some random question about cystic fibrosis. So what's the organism that can cause respiratory tract infection in in children?
Aspergillus for aspergillus. Okay.
Staph aureus.
No,
Staph aureus.
in children, Staph aureus. Mm. So
Staphylococcus.
in
Okay,
adults,
adult is this one.
in adults,
Pseudomonas
Pseudomonas.
pseudomonas. So we want to watch out for pseudomonas. Um, um, then remember all those things that they can have. So you can have chronic bronchitis, bronchiectasis, and you see this reticulonodular opacity on the X-ray with um some other GI problems. Do you remember the GI problem that we have that they can have? Anything. Okay, let me just paint this scenario. You have a 2-year-old lady, two-year-old baby that starts presenting with vomiting, um, um, vomiting, abdominal distension, abdominal pain. So the baby is always crying, and uh, you are aware that the baby has cystic fibrosis. So what do you think can explain that condition in someone that has cystic fibrosis? Anybody? Abdominal pain, distension, and vomiting in a child with cystic fibrosis. There's a particular diagnosis that I'm trying to tailor our mind to. But okay, what is that? What is that picture that I've painted? What is that? Abdominal pain, vomiting.
Obstruction.
That is
Intestinal
obstruction.
obstruction.
That is obstruction. So if you are seeing intestinal obstruction in someone with cystic fibrosis, what do you think is the most likely cause?
Meconium ileus.
Meconium ileus. Thank you, Dr. David. Meconium ileus. Please, we have to pay attention to that stuff. Meconium ileus is the cause of small intestinal obstruction in people with cystic fibrosis due to insipitated mucus, thickened mucus. We should not forget that, please. Of course, we should remember the liver problems, the biliary cirrhosis, the liver issues, pancreatic insufficiency, and the other thing. Everything is due to the fact that mucus is thickened everywhere and it's causing problem. Okay? Yeah, meconium ileus. Oh, this is the remaining part of the graph that Dr. Abisola was looking for.
Okay. So it will be it will be D.
Exactly.
Is it
Exactly. It's D. That is it. Yeah. So guys, we call it a day. So we've solved a lot of questions from metabolism. I don't think there's any other question that they can ask us that we'll not be able to take care of with respect to metabolism. So um I think, do you have any question? Just have to call it a day now. Do you have any question from anybody? Any question? Okay.
Sorry, Dr. Babawale.
Yes, Dr. Adu.
Sorry, please, just a quick recap. The very last question Dr. Toby took.
Okay.
Sorry, how come the answer was a transcatalysis? Sorry, I didn't get that, please.
Yeah. So look at it. They said the cells are unable to generate NADPH from glucose metabolism. They are unable to generate NADPH from glucose metabolism, but they are able to convert fructose 6 to ribose 5 phosphate. They are able to convert
Okay.
fructose 6 to ribose 5. Which of the following enzyme is essential for that latter, conversion? So let us go to the so this is Dr. Adu, you can see the conversion. Fructose
Oh,
6,
sorry. Okay, the latter. Okay, photo 6 and ribose. Okay, ribose 5. Okay.
you can see.
Sorry. I get it.
Yeah, so
Thank
that's
you.
no wahala. So guys, we'll call it a day. We are going to meet next time. I'm not sure I'll be able to meet on Friday, so we need to cover a lot too, so that we can have a lot of questions to solve together.
Dr. Babali, before we go, what's the purpose of the TCA cycle?
Yeah.
Is it just for the generation of FAD, GTP, and NADH?
Yeah, so that is it, Dr. Batobi. That is one of the function. That's the major function of TCA cycle. Your TCA
Because
cycle,
it doesn't give us any metabolites like them HMP shunt and the likes. I just want to understand what that pathway is for.
yes. So TCA cycle is just there to generate the energy containing molecule. What are these energy containing molecule? NADH, FADH2, and GTP. Do you know where it's going to make sense to you, Dr. Adiola? It's going to make sense when we get to the electron transport chain. So that is where Dr. Babayinde most likely will talk about that mallet shunt, because you really need to understand what's happening there. So,
Okay.
do you know what will happen? All those NADH that we are forming, that is accumulating, all those NADH that we are forming
Yeah,
from
they donate proton. They
exactly
donate
everything,
an
everything
electron.
will now be taken to the electron transport chain. Everything will be taken to the electron transport chain so that you can convert them to ATP. That is it. That is it. So Dr. Binde is going to talk about electron transport chain. We are going to talk about the complexes, complex 1, 2, 3, 4, 5. Then
Yeah, we've talked about them.
you've talked
Oh
about
yeah, he was mentioning that. Yeah.
We've talked about
so
complexes,
so
yes.
you guys already get the stuff. So all those NAD that you are forming, they are energy containing molecule. So that you can that is why TCA, anything that gets with TCA will synthesize a lot of energy. That's the ideal stuff. A lot of energy.
So from that TCA, the NADH just goes into the oxidative, the electron transport chain immediately.
Exactly. Immediately.
Okay. Then the FAD and the likes, where do they go? What do they do?
FAD also goes to the electron transport. You remember the complex 2? What is in the complex 2?
Yeah. FADH.
FAD. So the
Yeah,
complex
that's
2 is
true.
just that
True, that's true.
exactly. It's just that the transfer of electron in complex 2 is at a lower energy level. That is why FAD is generating just 1.5. Why NADH is generating as high as 2.5 or 3, depending on what you are using. So FAD contains very
Okay.
small, very small. You see that FAD, NAD difference is also the reason why the malate aspartate is generating 32 ATP and your glycerol 3 phosphate is generating 30 ATP. Maybe one of these days we just talk about it and you guys understand all those things.
It is well. Thank you very much.
So guys, I wish you guys a very good night rest. So I think maybe we are going to continue maybe on Monday, depending on how far we've gone. That will determine when we are going to meet next. Maybe Monday, because I'm not sure Friday will have done something. We'll still be, let's just see how it goes. But let's just keep Monday in our mind. So all right.
Thank you,
So bye bye
Baba
everybody.
Wale.
Bye bye everybody.
Yeah.